Good afternoon and welcome to this bill hearing for the House Health Committee. I'm Chair Heather Bagnall here with our amazing committee. I ask for your patience. Folks, thank you. We're starting. We're live. It's okay. I know, we're all excited. A lot is happening. I ask for your patience if we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel. Now, we do have a few virtual witnesses today, so please bear with us as we go back and forth with the technology. Please note that food and beverages are not permitted in the gallery. Delegates may have drinks at their desks as meetings can run long and hydration is really essential. Please make sure to turn off your phones or silence them at this time. If a member is not present in our gallery, please be aware that we do have hearings in other committees, that we have other meetings, but they are staying up to date on our proceedings. And this is the time of session where you will see people coming and going, but we are doing a lot of really good work. Please adhere to our usual committee rules of one question and one answer from the panel, not one question and one answer from each panelist. And please do keep your questions shorter than the answers. Once again, our sponsors are not time limited on their testimony, but please, keep it within reason so we never have to revisit that rule. And all witnesses have 2 minutes. The bill order for today is as follows. It's House Bill 1385. 1450, 1469, 1133, 1134, and 1316. Of course, subject to the availability of the sponsors. So we are going to start with House Bill, we're actually going to start with House Bill 1450, which is Health Insurance Coordination of Benefits, Carrier Responsibilities, and Retroactive Denials of Reimbursement. The Delegate Johnson, if you want to go ahead and approach the table and bring your panel, and you can get started when you are ready.
Madam Chair, like you said, there's a lot of things going on, so I think I'm going to be my panel for today.
You are enough, exactly.
All right. Good afternoon, Madam Chair, Vice Chair, and members of the Health Committee. For the record, I'm Delegate Steve Johnson, here to present House Bill 1450, Health Insurance Coordination of Benefits, Carrier Responsibilities, and Retroactive Denials and for Reimbursements. Many Marylanders have more than one source of health coverage. For example, a person may be covered through their own employer and also through a spouse's plan. In these situations, insurance companies must determine which plans pay first and how the remaining costs are covered. This process is called coordination of benefits. In theory, coordination of benefits should ensure that the claims are processed smoothly and that the patients are not overcharged. In practice, however, the system also often creates confusion and delays. Providers submit claims to one insurer only to have the claim delayed or denied months later because another insurer should have been billed first. In some cases, insurers retroactively deny payments long after services have been provided. When that happens, providers may be forced to resubmit claims or seek payment elsewhere, creating administrative burdens and uncertainty for both the providers and the patients. House Bill 1450 addresses a frustrating problem in our healthcare system. When multiple insurers are involved in paying for care, patients and providers can get caught in the middle of disputes between insurance companies. This bill establishes clearer responsibilities for the insurance carriers when coordinating benefits and limits how long they can retroactively deny reimbursement. Specifically, the bill requires health insurance carriers to identify other payers when a claim involves coordination of benefits. It requires carriers to identify the amount of payable by the other payers and coordinate benefits with them directly when appropriate. And it reduces the time period in which carrier may retroactively deny reimbursement related to coordination of benefits, issues from 18 months to 9 months. For patients, clear coordination rules reduce the risk of surprise bills and administrative complications. For the healthcare providers, the bill helps ensure that the claims are processed in a timely manner and reduces the administrative burden caused by retroactive denials months after the services are provided. For our healthcare system as a whole, better coordination between insurers improves efficiency and reduces unnecessary paperwork and disputes. This bill does not create new benefits or increase coverage mandates. Instead, it improves how existing insurance processes work so that claims are handled more predictably and more transparently. Now, I know there's a lot of things to be worked out in this bill. This bill in concept is trying to come up with an idea or a plan where we can have better coordination of benefits. If you look in the opposition to the bill, they bring up some good points that we will continue to work with all stakeholders and try to work these out to get this bill to where it's a workable, actual strategy that works for the patients, the providers, and the insurance companies. And with that, I would ask for a favorable report on House Bill 1450.
Thank you for your testimony. I'm just looking to see if Dan Doherty is here. Mr. Doherty, do you want to come up and give your testimony? I know you were part of the sponsor panel.
Thank you, Madam Chair, members of the committee. I'm Dan Doherty here on behalf of the Maryland State Dental Association and the Maryland Society of Oral and Maxillofacial Surgeons. I think the sponsor has outlined what the bill does very well. There's no reason for me to repeat that. I do recognize, as he does, there may be some issues that need to be worked out, and I and my clients are willing to work with the stakeholders to try and get to a finished product. And with that, I would urge you to favorably consider the bill as we work through this process.
There's nothing we love more than a collaborative Me Too. Now I will go ahead and open up to the members. Are there any questions for this panel, for the sponsor? Seeing none, thank you very much for your testimony. We do have an unfavorable panel, so if I can call Joseph Wynn and Michael Johansson, you can come up to the table and give your testimony when you're ready.
Thank you, Madam Chair.
You had theme music for a moment.
I did, yeah, thank you. I'm Mike Johansson on behalf of Maryland Physicians Care, MCO. Medicaid managed care organizations are required under our agreement with the Maryland and under their agreement with federal CMS to be the payer of last resort, which often means we need to determine whether or not there is some other carrier that is responsible for the claim that is submitted. I agree, it's probably a very messy process for the provider, but the carrier can only do what it can do with the information it has. The bill, for example, suggests that an MCO would be responsible for not only identifying the primary and secondary payers, but also for determining the amounts payable by each payer. And I'm not so sure that that is, in fact, information that we would ever be in possession of. So it's not something that we would be able to do. Also, if we find that a claim is submitted and there's an indication in the claim that it, for example, is a work-related injury, that would tell us as a managed care organization that it could be a workers' comp claim. So we would deny it simply because it's a workers' comp claim. Suggested it go to workers' comp first. We wouldn't even know the name of the other, carrier or payer in that situation, but it would give us reason not to pay it. So we don't disagree with the goals of making a messy process simpler, but it just isn't something that we are in the position to help with respect to the language that we see.
Thank you very much for your testimony. And just double checking, Joseph Wynn is not in the gallery. Okay. I'm going to open it up for questions. Are there any questions for this witness? Seeing none, thank you very much for your testimony. This concludes the bill hearing on House Bill 1450. We're now going to go to House Bill 1385, which is Health Insurance Use of Artificial Intelligence Human Evaluation. Delegate Hill, if you'd like to approach the table and bring your panel, and you can begin your testimony when you're ready.
Good afternoon, Madam Chair. And good afternoon, members of the Health Committee. For the record, I'm Terry Hill, Howard County District 12A, and I'm here to present House Bill 1385, Health Insurance Use of Artificial Intelligence Human Evaluation. This committee and the General Assembly last year passed House Bill 820, which set up some parameters for how artificial intelligence and other automated algorithmic systems are used in determinations of health coverage, denials, and approvals. It sort of set guardrails for what we wanted to do, and then there was a reporting requirement included as well. In looking at that legislation, however, after it passed, what we realized is that one of the things we tried to do was create a human in the loop where denial decisions are being made. And the human in the loop is the person who supposedly is looking at more than just what the algorithmic input data is, but actually in a position to look at the specifics for the particular care and make a decision that is more informed. And this bill essentially tries to fix that problem by actually defining or redefining artificial intelligence and talking about what that human in the loop looks like. So it really is a simple bill, and if you note the opposition, for instance, from the health insurers and the League of Life and Health Insurers of Maryland, basically says that they oppose it because statute already does this, and that's because we passed the bill last year. But again, the bill last year was not specific enough about what a human in the loop is. And in fact, after we passed the bill last year, we realized that they kind of already have a human, but if the human being is simply saying, yep, the algorithmic system just did exactly what it was supposed to do, then that really has no value to anybody. If we think about systems we're more familiar with, like speed cameras, or red light cameras. We know that there was a difference when we simply trusted that the camera was determining who got a ticket than when we had those videos viewed by real life people who were able to find all kinds of problems that were not out of line with the algorithm, but were catching people and accusing them of doing things that they actually weren't doing. So it's the same idea. We know these systems fail. We want to be clear that when we put a human in the loop, that they're there to look at different data, not just to affirm that the algorithmic system worked as it was designed to do. There are a couple of amendments that we're offering, clarifying the definition of artificial intelligence, clarifying the use of group data sets, clarifying AI assistance and final decision authority, clarifying audit and inspection requirements, including that the human in the loop should be board certified or board eligible in the specialty of which the determination is being made. So we're not going to have an OBGYN reviewing or doing the audits for a cardiology case. That would not serve much purpose, but it would be appropriate for someone who's a cardiologist to review that information. So I would ask, with the amendments that we'll be offering, that you find favorable on this bill, cleanup bill.
Thank you for your testimony. I do have two favorable with amendments on your sponsor panel. Do you want me to call them up?
Yes,
now?
please.
Okay. So Daniel Doherty and Dana Kaufman, if you want to come to the table and go ahead and give your testimony.
And while they're coming up, I would note that the fiscal note is a little bit iffy, and I think we can we can work along that. I mean, it's just under the line for the first year, but I think we can talk and see if we can get that down a little bit, okay?
Go ahead, Dan.
Chair Bagnall, members of the committee, for the record, my name is Dana Kaufman. I'm here on behalf of MedChi, and we are in support of this bill with the amendment that Delegate Hill referenced, and that is making sure that the human reviewer is somebody who actually is in the same, either board certified or board eligible in the same specialty and has actual clinical knowledge of the treatment. And this language is actually borrowed from the prior authorization bill that passed in 2024. And you probably have heard me ask this a couple times when similar situations have come up, but I'm just going to give you an example that was one of the reasons we requested that that language be put into the prior authorization bill. There was an issue dealing with ophthalmology and macular degeneration in the treatment. And the individual who participated in the peer review at that time was a pediatrician. Now, I can assure you that pediatricians have very little practice in macular degeneration. And he, basically admitted that. But that is the reason that we are asking, because without it, then it really serves no purpose to have a human reviewer, and in areas it just delays treatment. So with that amendment, we would ask for a favorable.
Thank you, Madam Chair, members of the committee. Again, Dan Doherty on behalf of the Maryland State Dental Association and the Maryland Society of Oral Maxillofacial Surgeons in support with the amendment. The amendment is similar to what was discussed by Delegate Hill as well as Ms. Kaufman. Although board certified or board eligible does not necessarily work in dentistry. You have a license granted, and there are various ways different people will be providing services where there may be a specialty, but you don't have to be board certified. So we would suggest that the professional be qualified and knowledgeable about the healthcare service or treatment through actual clinical experience. And that way, we avoid the problem of carving people out because they aren't board certified or board eligible.
All right.
And with that, I would urge a favorable report with amendments.
Thank you for your testimony. Are there any questions for this panel, for the sponsor of this panel? Seeing none, thank you very much for your testimony and for the bill. And this actually concludes the bill hearing on House Bill 1385. We're now going to go to House Bill 1469, which I understand the Vice Chair's amazing intern, Marwa Mamandi, is going to be presenting. So if Ms. Mamandi, you want to come to the table and bring your witness panel. Yeah, I have a sponsor panel of Michael Patty, Sarah Price, Dana Kaufman, and Caitlin McDonough. If you want to come to the table, and you can get started with your testimony when you're ready. And Ms. Mamamdi, is this your first time presenting for the committee?
It is, yes.
All right, well, welcome.
Thank you so much. Good afternoon, Chair Bagnall and honorable members of the committee. Thank you for this opportunity to present House Bill 1469, Health Insurance Specialty Drugs. This bill seeks to revisit the definition of specialty drugs for the purpose of clarifying how these pharmaceuticals are dispensed to assure access and fair cost sharing. The specialty drug has a specific definition, which demonstrates how these drugs are different from others. In 2014, this body passed a law to describe them in this way in the Maryland market in Section 15847 of the Health Insurance Code. Is prescribed for an individual with a complex or chronic medical condition or a rare medical condition, costs $600 or more for up to a 30-day supply, is not typically stocked at retail pharmacies, requires a difficult or unusual process of delivery to the patient in the preparation, handling, storage, inventory, or distribution of the drug, or requires enhanced patient education, management, or support beyond those required for traditional dispensing before or after administration of the drug. In addition, the law authorized insurers to use specialty pharmacy networks to distribute specialty drugs and prohibited insurers from imposing a co-payment or co-insurance over $150 for a 30-day supply of a specialty drug. While pharmacy benefit managers, or PBMs, have been around since the 1960s, their roles and operations changed dramatically in the 1990s. National pharmacy chains and drug manufacturers began to acquire PBMs, significantly changing their role in the drug pricing chain. PBMs utilize the current definition of specialty drug to dispense them through affiliate and specialty pharmacies, steering patients away from local retail pharmacies. This increases profits for PBMs, which in turn drives costs in commercial and Medicaid markets. The current definition is also outdated and fails to account for modern prescription drug pricing structures. Out-of-pocket costs for Marylanders have increased by thousands since the definition was introduced in 2014. A new definition of specialty drug is needed to distinguish which drugs need the categorization, addressing the rising costs of prescription drugs, allow for patient choice and trusted local pharmacies, and ensure greater transparency in the drug pricing chain. Thank you for your consideration, and I ask for a favorable report. Thank you.
Michael Patty here today on behalf of the independent pharmacy owners of Maryland in support of the bill. We're glad that we got onto the work group. There's a number, this issue's trying to been solved since the definition got into law in 2014. I think I counted about a dozen or so bills since then trying to amend the definition to make sure more of these drugs are dispensed at your local independent pharmacies. Since 2014, there have been a number of conditions that have been carved out, such as diabetes, HIV, and AIDS, so that you can go to your local pharmacy to get these drugs. So there's a lot of work to be done. Other states have taken different approaches, so we understand the need to continue to discuss this in a work group setting, and with that would support the bill. Thank you.
Chair Bagnall, members of the committee, again, for the record, my name is Dana Kaufman. I'm here on behalf of MedChi. We support the bill, but we do think that the work group needs to be better balanced. Right now, the work group has 9 members. 5 of the members represent insurers or pharmacy benefit managers. 2 are pharmacists, 1 is a hospital, and 1 is a healthcare provider that is not a hospital. We would respectfully request that the work group be altered to include 2 physicians who prescribe specialty medications to treat their patients. We think that that is a very important voice that needs to be included on this work group. And with that amendment, we would urge a favorable vote.
Good afternoon, Madam Chair and honorable committee members. Sarah Price on behalf of the Maryland Association of Chain Drug Stores. We do feel that additional work in this area is very necessary. We are very supportive of the establishment of a work group. But upon additional feedback from our members, I probably should have signed up favorable with amendment because we have been asked to request chain representation on the work group. I know that chains often have a bad reputation when we're talking about PBMs, but none of our members are affiliated with PBMs in Maryland. So we do feel that it's important to have that voice in the room when this discussion is being had. Thank you.
Good afternoon, Madam Chair, members of the committee. Caitlin McDonough on behalf of Epic Pharmacy Network and Maryland Oncology and Hematology. We echo the panel and the sponsors' willingness to look at the definition. I think one thing that's really led us to this is how differently specialty drugs are defined and classified across all the different carriers and PBMs. And we would also note, while it's very important to look at this definition, there are so many areas of Maryland health policy that tie back to it related to steering and access and dispensing on both the provider and patient access side. So, in addition to looking at the definition, looking at how it plays in Maryland's health policy is going to be very important. And I would echo support for all of, we would agree that there could be more balance on the work group as drafted. MOH is a provider that, as oncologists that prescribe a lot of specialty drugs. They have a medically integrated dispensary on site. That legislation, we worked with the vice chair and the committee and Delegate Johnson to pass legislation to create more access there in previous years. So those kinds of voices being on the committee, as well as our non-PBM chain pharmacies, I think would be helpful to bringing all those voices to the table. So thank you, and with that, we'd urge a favorable report.
Thank you very much for your testimony, and thank you, Ms. Mamamdi. You represented our vice chair very well in your first bill hearing before this committee. With that, are there any questions for the witness or for the sponsor or their panel?
Oh, okay.
Don't panic. Are there any actual questions for the sponsor or their panel? Seeing none, thank you very much for your testimony. We do have one witness for information, and that is Mary Quay. If you want to come up and give your testimony.
Good afternoon, Madam Chair. I am Mary Quay. I am the Associate Commissioner for Market Regulation and Professional Licensing at the Maryland Insurance Administration. And I am also the co-chair of a work group that was established last year to look at a variety of issues around pharmacy benefit managers. And one of those charges touches on specialty drugs. And we were planning to look at specialty drugs as a group this year. And we would be happy to incorporate the charges in this bill into the current existing work group.
Thank you very much for your testimony. Are there any questions for this witness? Delegate Shalega, followed by Delegate Hill.
Thank you, Mary. So are you saying we don't need a new work group? We just need to change the bill to say add this to, and what's the name of your work group?
I would have to look at the specific wording of the work group name. It is a joint work group with MDH and the MIA and a number of stakeholders from a variety of backgrounds.
All right, that'd be great if you'd get that information to us so we can offer an amendment and streamline it. Thank you.
Delegate Hill.
Thank you, Ms. Quay. Just real quick, when you get that information, unless you can tell us here, can you tell us what the makeup of that work group is? And what you heard about representation?
I can get that to you. I don't know off the top of my head. It is quite a large list of people.
Okay.
And we include the PBM industry, independent pharmacists, self-funded plans, chain pharmacies. I don't know the others included off the top of my head.
All right, thank you.
We can get that and get that to the full committee. Seeing no further questions, thank you very much for your testimony. Delegate Johnson.
Thank you, Madam Chair. I was wondering, on the other work group, can you tell us how a specialty drug can be considered by one group and not another?
There are definitions that are in place in the insurance article that outline the general requirements for a specialty drug, but one carrier might read them and apply them to certain drugs, and a different carrier might say that certain drugs are outside of that. One of the requirements, for example, would be special handling, and some carriers might think that a community pharmacist could handle that, and another carrier might say they need a specialty pharmacy.
Follow-up, Madam Chair? Thank you. Do you think it would be good to get that consistent across the board?
I think that's one of the things that we are looking at how to make the definition one that will be applied more consistently and leaves less room for interpretation.
Thank you. Thank you, Madam Chair.
Thank you very much. Seeing no further questions, this does conclude the bill hearing on House Bill 1469. Thank you very much for your testimony. We are going to move to House Bill 1133. Delegate Taveras, would you like to do your bills back to back? Okay, so 1133 is Public Health Drug Manufacturer-Funded Disease Awareness Campaigns, Registration and Required Disclosures. So Delegate Tavares, if you want to head to the table, and we'll roll right from one bill to the other. So go ahead and bring up your panel for House Bill 1133, and you can get started with your testimony when you are ready. I do see that you have a virtual witness on your sponsor panel, so we'll bring them up as well.
Come on, ladies, let's do this. So this one, where do I sit? Let me be in the middle and y'all can surround me.
So for this one, it's just me
Okay.
and someone online.
Okay,
We got
all right,
Miss Lydia Green.
all right, let's do this.
The other one, you got a whole team.
Okay. Okay. Thank you, Madam Chair, and everyone, and members of the committee. Thank you for the opportunity to present HB 1133, and I respectfully ask for your favorable report. HB 1133 addresses a transparency issue related to industry-funded disease awareness campaigns. Across the country, pharmaceutical and medical device companies fund campaigns designed to raise awareness about certain medical conditions. These campaigns often appear as public health education, encouraging individuals to recognize symptoms and speak with their doctors. While raising awareness about disease can be beneficial, these campaigns may also coincide with the development or promotion of specific treatments. In those cases, the public may not always know that the campaign is funded by a company with a financial interest in the condition being discussed when a cheaper treatment is available. This is the Recognize Depression Signs poster, sponsored by an antidepressant manufacturer, or the breast cancer or mammogram ad hosted by an oncology specialty drug manufacturer. HB 1133 does not, and I repeat, not prohibit these campaigns or limit free speech. And let me repeat that, it does not do these things. Instead, the bill simply requires transparency. Under this legislation, when a manufacturer funds or materially supports a disease awareness campaign in Maryland, that activity must be reported to the Department of Health. That's it. The report would include information about the campaign, the funding provided, and whether the manufacturer markets or develops a drug or device related to the condition discussed. The department would then make this information publicly available to Maryland residents, policymakers, and healthcare providers, and healthcare providers can better understand the financial relationships behind these campaigns. This approach promotes transparency while allowing disease awareness campaigns to continue. The goal is simply to ensure that Marylanders know who is behind the messages they see. Stakeholders today will speak in greater detail about how these campaigns operate and why transparency in this area is important. For Maryland residents, this bill is about trust, transparency, and informed decision-making in healthcare. I respectfully ask for a favorable report on HB 1133. Thank you.
Thank you for your testimony. We'll start with your in-person witness, and then we'll go to your virtual.
Thank you. Good afternoon, Chair Bagnall and distinguished committee members. My name is Caroline Renko, and I am testifying in favor of House Bill 1133 for Farmed Out, a project at Georgetown University Medical Center. We study how pharmaceutical marketing affects prescribing. Our disclosure is that Farmed Out has previously received funding from Kaiser Permanente. Lastly, I'm also a Maryland resident. I'm going to start today by giving you a recent example of a disease awareness campaign that we studied in detail. In 2021, a campaign was launched nationally on mild cognitive impairment. Consumers were told that mild cognitive impairment was most likely due to Alzheimer's and that it affected 1 in 12 Americans. Both of these statements are false. The campaign's website also helpfully offered a symptoms quiz. A person who said they had no symptoms was still directed to ask their doctor about cognitive screening. This campaign, like other industry-sponsored disease awareness campaigns, was about drug promotion, not public health education. It was launched about a month before the company's Alzheimer's disease treatment was approved by the FDA. All the campaign materials were designed to scare normally aging Americans into thinking that they had Alzheimer's, which the sponsor now conveniently had a treatment for. HB 1133, again, does not prohibit disease awareness campaigns, but will inform Maryland residents that they are looking at materials created by a company selling a treatment for the exact disease that they are reading about. The Alzheimer's campaign that I mentioned is not a fluke. Industry-funded disease awareness campaigns are vital for marketing expensive drugs and preparing for treatments that are in the pipeline. Marketing drugs prior to FDA approval is illegal. However, marketing diseases is not. So pharmaceutical companies sell diseases years before their treatments are approved. Pharmaceutical companies will also sometimes partner or create advocacy groups to manage these disease awareness campaigns on their behalf. HB 1133 does not prohibit this, and HB 1133 does not limit speech. Again, it simply ensures transparency in communicating to Marylanders. Thank you.
Thank you for your testimony. Great timing, too. Lydia Green, if you want to go ahead and unmute and begin your testimony.
My name is Lydia Green. I trained as a pharmacist and worked in pharmaceutical advertising, developing branded advertising and unbranded disease awareness programs. I'm the founder of RX Balance, a nonprofit working to increase transparency around medical information. I am here in support of HB 1133. Today, I hope to explain how companies use unbranded disease awareness programs to market their products. I have worked on many disease awareness programs, including depression, pulmonary disease, osteoporosis, schizophrenia, and ADHD. Unlike product advertising, unbranded disease awareness campaigns are designed to expand the number of patients eligible for drug treatment. Unbranded programs promote medical conditions and treatment goals, the target number people are told they should reach. These programs are part of a commercial strategy designed to increase the number of people who see themselves as candidates for treatment. Without disease awareness campaigns, Americans today would not be taking as many prescription drugs as they do. HB 1133 does not prohibit these campaigns or the important work of patient advocacy organizations and medical associations. It simply requires transparency if pharmaceutical companies fund them. Since these unbranded campaigns shape how people understand diseases and treatments, the public has a right to know when they are funded by industry. Thank you.
Thank you for your testimony. Are there questions from the members for this panel? Delegate Morgan, Delegate Kaufman, followed by Delegate Morgan.
Yes, Delegate Taveras, this is a great bill. I was just wondering if you had had the opportunity to read the opposition testimony for the Biotechnology Innovation Organization, where they say the bill is harmful to patient health, and that unbranded campaigns are essential to helping people access patient care. I just wanted to know if you had a response to that.
Well, I also disagree with their position. To me, we already collect a lot of data at the federal level, especially after OxyContin, right? I mean, I think that how do I say this? We recognize that this industry spends almost $1 billion a year to lobby, right? Right now, we unanimously passed a bill to allow Ozempic or weight loss medication to be paid by Medicaid, right? We don't know what percentage of that, but the thing is, they're making 14 to 35 billion. And no shade on that. I don't think that no one here is doing anything wrong. But it's good to know. It's good for us to know what's being invested, because on March 10th, FDA just said that this company did not report the side effects leading to 2 deaths and a suicide. It's good to know. If there is a campaign that's happening, there's nothing wrong with having a line that says, this is being sponsored by. There's nothing wrong with that.
I agree. I just wanted you to have the chance to respond. Thank you, Madam Chair.
We're not violating anybody's.
Delegate Morgan, followed by Delegate Hill.
Thank you, Madam Chair. Thank you for the bill, Delegate. Novel idea here. I'm just wondering, you mentioned a couple times about this doesn't infringe on free speech, but there would be concerns under free speech. I mean, you mentioned it a few times. And I was wondering, you mentioned also about the money manufacturers make in this, and that's the driving force behind it. But there's other entities in healthcare that also make a considerable amount of money. Hospitals, insurance companies, PBMs. Have you ever thought about applying it to all those facilities, the same requirement?
I mean, right now we're starting here. It's a first step.
But wouldn't that just single out one manufacturer?
Huh?
I mean, wouldn't that single out one segment of healthcare and not really apply it uniformly?
All I'm saying is that I attended a conference this summer hosted by the Kaiser Permanente Health Institute, which was the reason why I got interested in these issues. And developing that conversation, this was just the first step. I'm not saying that we shouldn't look anywhere else, because I'm sure we could try to find, other cost savings in the process, vertically, for sure. But for right now, this is where we are. And I think that, as we always have been in this state, we are one of the trendsetters. And this is a trend-setting law that we would pass and set a standard that has never existed before.
No, thank you. Thank you, Madam Chair.
Thank you. Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Tavares, for this bill. See what you're trying to do here. I like that. I know there's some legislation elsewhere. Well, anyway, we'll keep going. The American Heart Association has a letter of concern. It's opposition, but they're concerned that advocacy groups will be caught up and have to have sort of excessive costs because they say that oftentimes they're running educational campaigns. They have lots of funders. They don't know if a funding is being targeted or what have you. Is there some language that you'd be willing to consider to separate the kinds of campaigns they're generally running or those kinds of groups are running from ones that are really specifically targeted to promoting a disease for the purpose of? Or do you want, if you're doing a promotion, tell us what you know about who's funding it?
Well, I'll say this. I've talked to a lot of the people that were unfavorable, you know, and including the American Heart Association. And let's just say that the state folks here did not really express a concern, that they were told that this is what they had to prepare for this bill out of headquarters because somebody that was in funding received a call. If that's not influence, I don't know what is.
Thank you. Okay. So probably not as burdensome as the letter suggests. Thank you.
Thank you. Seeing no further questions. Delegate Chalega. But just one moment. I just wanted to make sure that we were correcting the record because there was a discussion that we had passed.
Well, we hadn't, but I mean.
The bill that we passed, to be clear, was on authorizing the department to consider drugs that came on, that the feds decided while we were out of session that they could consider them for applying for a waiver.
I love how you do that.
And it did not pass unanimously. So I just want to make sure we're setting the record straight.
Thank you. I love you.
Chalega.
I love you. I love you, Chair Bagnall.
Thank you, Madam Chair. So fiscal note says sufficient information was not available, blah, blah, blah. But I'm reading the bill, as you know I always do. And this will charge the Maryland Department of Health to set up a registration program. So if my understanding is correct, they're going to set up a program where drug manufacturers and certain patient advocacy organizations will register with the Department of Health, and then they'll keep a database of whatever information is, so that clearly that's going to have a fiscal note of at least a couple people to do that. And then finally, what is the penalty if people don't? You don't have a penalty in here. So if a drug manufacturer or advocacy organization says, I'm not going to register with the Maryland Department of Health, blah, 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 there's no penalty.
I do believe there is a penalty. I think it's 10,000 per.
Did I miss it? I read the bill. I don't
It's
see it.
10,000 per violation.
Where was that? Somehow I missed that. Okay, 10,000.
Page 3.
Page 3, okay. $10,000 if somebody doesn't register with the Department of Health. Do you
But
think?
before imposing a civil penalty under this section of the section, the department shall provide notice and the opportunity to cure the violation, so they'll receive a warning first.
Okay. So I will just say to you, I'm a little concerned about the fiscal note with this looming massive structural deficit and $70 billion budget we're facing. What are your thoughts on that?
Well, with regards to I think it's minimal, but with that said, I do want to make a note to say that hold on a minute, maybe I want to make sure that I'm quoting them right. The Maryland Department of Health Advisory Council on Hereditary and Congenital Disorders is supportive of this. So, and there's a list of members of which we have Delegate Terry Hill on that list, and they have approved it and they are favorable.
Okay, so you think they could manage this? Maybe we should ask.
Well, I mean,
Thank
if it's,
you.
if it's across the
Thank you.
top, it says that it's Westmore, Aruna Miller, the governor, lieutenant governor, Amina Seshamani, the secretary, are all ahead of the council. You're welcome.
Seeing no further questions, Delegate Taveras, I think you might be looking, have you been amending this bill? Because I think you might be looking at a version that we don't have before us, which is why
We
you're
do
hearing
have
some
an amended
confusion.
version of the bill.
That, I think that may be where some of the confusion is coming from. Delegate Shalega.
The bill does not have a penalty in it, so there's an amended, or it's the next bill you're going to.
Okay, we'll get you the amended version as quickly as possible.
Yeah, so we
I'm sure
are
my
looking at a
staff
different
is-
version of the bill than you were looking at. So that may be where some of that confusion is coming from.
Yeah.
We do have two favorable witnesses on this bill, so thank you very much for your testimony. If I can bring Allison Taylor and Matthew Celentano to the table, you can come and give us your testimony. And then we have one unfavorable panel. Thank you. And you can begin when you're.
Thank you, Madam Chair. Matt Celentano today here on behalf of the League of Life and Health Insurers in support of House Bill 1133. Drug manufacturer-funded disease awareness campaigns and groups often function as covert marketing tools. They steer patients towards high-cost branded drugs, or they've even seen a doctor. By requiring disclosure of the manufacturer's financial interest and the specific drug being marketed, the bill helps expose that dynamic. Insurers who bear the cost when patients receive extensive branded treatments over cheaper alternatives have a direct financial interest in ensuring patients aren't being preconditioned by undisclosed marketing. While manufacturer-funded campaigns masquerade as neutral public health education, it can breed public cynicism about all health messaging, including insurance-sponsored wellness programs. A clearer boundary between genuine public health education and commercial promotion benefits insurers who rely on member trust and engagement with their own health outreach initiatives. The League has begged the pharmaceutical manufacturers to come to the table for years to justify their out-of-control price increases. They obviously never do so, although I'm surprised to even see them here today, and they send front groups to carry their water. House Bill 1133 would provide necessary transparency to know exactly who you all are speaking with when you consider legislation. We urge a favorable report on House Bill 1133.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente and want to thank the sponsor for coming to an event that our Institute for Health Policy had last summer where some of these issues were discussed. I see this bill as very analogous to the structure that the state has put in place for lobbying. You know, people are able to come here and express the opinions that they have. We just are required to register and report who it is that we're speaking on behalf of. So for that reason, I think it's a common sense approach and look forward to continuing the conversation. Thank you very much.
Thank you for your testimony. Are there any questions for this panel? Delegate Martinez.
Really didn't have questions on the bill, but your testimony inspired some. I have a question. The organizations that you mentioned that are these fronts, do they not have registered lobbyists here in Annapolis?
Some of them do.
So it's a yes, they do have registered lobbyists?
Correct.
Thank you.
Seeing no further questions, thank you for your testimony. We do have one unfavorable panel. Oh, excuse me. Kristen Pard, Josh White, and Kelsey Haddo, if you could come to the table and give us your testimony. Sorry, friends, allergy season is killing me.
Madam Chair, Madam Vice Chair, members of the committee, my name is Josh White on behalf of the Pharmaceutical Research and Manufacturers of America, or PhRMA. Patient advocacy organizations often collaborate with researchers and pharmaceutical innovators to raise awareness about symptoms, disease progression, and treatment options. For many of these serious and rare conditions, these partnerships are essential in helping patients recognize symptoms and seek care earlier. However, this bill risks stigmatizing patient education, as we have seen over and over, especially from the insurance industry. This bill would treat awareness campaigns as inherently suspect, and by requiring a registration and imposing unworkable disclosure requirements, the bill creates a chilling effect around patient education that could discourage organizations from conducting awareness efforts and help patients recognize symptoms and seek care. Second, the bill presents significant compliance challenges. Disease awareness campaigns frequently involve multiple partners, including patient organizations, researchers, manufacturers, and it's unclear in this bill how responsibility for registration disclosures would work and who is going to be assigned to among all these parties, and which entity will ultimately be held accountable. The bill also appears to require disclosures of drugs associated with the condition, even when those therapies may be in development and do not have a public-facing name. In addition, campaigns often address symptoms of conditions broadly rather than specific products, making it difficult to determine what information is actually being disclosed. For all these reasons, we ask for an unfavorable report.
Madam Chair, Vice Chair, members of the committee, thank you for the opportunity to testify today. My name is Kristen Pardee, and I'm with PhRMA. We respectfully oppose HB 1133, which seeks to penalize patient advocacy organizations for their relationships with biopharmaceutical companies. Meaningful collaboration between patient groups and manufacturers ensures patient voices are fully included in decisions that affect care, access, and outcomes. These organizations provide support services, help families navigate care, raise disease awareness, and elevate the lived experience of patients. Insights that simply cannot be replicated by policymakers, researchers, or companies alone. These partnerships are also central to advancing research. Patient groups help manufacturers better understand disease burden, unmet needs, and treatment priorities. They also lead to better clinical trial designs. Importantly, these public campaigns and these relationships with the groups help patients navigate affordability and access. Many advocacy groups rely on manufacturer support to provide education, connect patients with assistance programs, and offer guidance on insurance coverage and out-of-pocket costs. This bill's administrative reporting mandates will divert resources away from these mission-critical works. Finally, this legislation lends itself to compliance confusion. It's unclear if the patient group or manufacturer should register with the department. If the patient group, does this mean they're responsible for knowing every compound in development that may become a medicine? If it's the manufacturer, does the patient group have to tell them of every public campaign they're doing? Additionally, it requires reporting of drug names before a medicine even has a final identity. And finally, just really quickly, if a campaign mentions the drug specifically, it triggers the FDA rules. And so, and those are the things where you're going to see the risks. You'll have the name of the drug in there. And even if it's recently indicated exactly which medicine it is. Most of the time, these are simply about, thank you for your time. Oh, thank you. Most of the time, these campaigns are about different disease, and those will usually have multiple companies that have drugs in development for that. So it's not one specific drug that they're talking about. It's not one specific company that's involved. And so it really is truly raising awareness about a disease.
Thank you very much for your testimony. Kelsey Haddow, if you can go ahead and unmute and begin your testimony.
Yeah, thank you. Chair, members of the committee, thank you for the opportunity to testify. My name is Kelsey Haddow, and I represent the Rare Access Action Project, otherwise known as RAP, a coalition dedicated to ensuring that rare disease patients have a voice in policy decisions that affect their access to life-saving therapies. I'm here to oppose HB 1133 because despite its title, this bill does not regulate drug manufacturers. It regulates patient advocacy organizations like ours. HB 1133 requires patient groups to register with the Maryland Department of Health before conducting any disease awareness campaign and to disclose specific products even when our work is not tied to any product promotion. For rare disease communities, this is not a small administrative step. It is a barrier to free speech and a deterrent to education. Most rare disease organizations are small, volunteer-driven, and already stretched thin. Adding a state-level registration requirement paired with disclosure rules written for manufacturers creates a chilling effect on the very groups that patients rely on for the most trusted information they get. And importantly, this is not how a state with limited resources should be spending taxpayer dollars. Maryland already struggles to find essential public health priorities, creating a new regulatory burden to monitor patient groups and groups that are simply trying to educate families, raise awareness, and help people navigate care is an unnecessary and inefficient use of state staff time and administrative funding. The bill assumes that patient advocacy organizations are extensions of industry. This assumption is wrong. Groups like RAP exist because patients need a seat at the table and have voices that explain complex policies that help families navigate care and elevate the lived experience of people who are often overlooked. It would force patient groups to navigate regulatory hurdles simply to educate Marylanders about symptoms, diagnosis delays, or barriers to treatment. At a time when rare disease patients already face long diagnostic journeys and limited access to specialists, Maryland should be removing barriers for information, not creating new ones. It risks silencing smaller organizations that cannot afford legal review every time they publish a flyer, host a webinar, or share a social media post. On behalf of Rare Access Action Project and patients who desperately need a voice in the Maryland legislature, I urge the committee to work with patients, communities on solutions that enhance transparency without silencing our voices. Thank you.
Thank you for your testimony. I'm going to open it up to questions from the members for this panel. Delegate Taveras, followed by Delegate Hill.
I'll let other people ask for questions first.
Delegate Hill.
Haddo, is she still on?
Yes.
Okay. Medical researchers have to disclose ties that they have. And they're also allowed to do a statement that says, I have no ties to any industry that needs to be disclosed, meaning I'm not doing this for the cardiac medication pharmaceutical company when I'm talking about heart disease. If this bill said for advocacy groups, that if there is a known relationship and funding for this campaign with a particular pharmaceutical that's germane to the disease being done, but you had the option of having a no disclosures to reveal and did not have to register, just would have to either list on any ad campaigns a relationship or say there is no relationship known. Would that satisfy what you're seeing as a overly burdensome requirement?
I think if we were looking for a compromise that would require something, having, AstraZeneca has sponsored this educational campaign. I don't think there's a problem with that. We do that on our flyers, on our stuff that we do. If we get funding, we do post, this was sponsored by. That is not a burden, but registering and paperwork and regulatory things that larger organizations have to fill out and putting those on. Most organizations are small mom and pop. We are not a large organization. And if we were to be filling out all those regulatory things just to have a webinar on prescription drug affordability boards, that would take up half the time it would creating the webinar.
So it's the registration that's particularly burdensome then. Thank you. Is that right? Okay.
Are there any other questions from the members? Delegate Taveras.
Okay. So, isn't it true that while there may be many There's no single funder directing the work, but there is a single funder is directing the campaign?
I'm not sure how to answer that question.
In terms of the campaign, it's being organized by a point person. Would that not be the case?
Again, I'm not sure we can answer that question because I'm not sure what you mean.
Okay. In terms of,
Did you want to follow up, Delegate Tavares?
yes, I just have a concern with the fact that it seems like, do you not think that it is illegal to market drugs that are, or a disease, well, support a disease when you are intending to market a drug that is currently in development?
I'm trying to figure out how that relates to the bill.
Yeah, I was going to say, I think we need to make sure the question is on the
So the
legislation that is before us.
is just requesting folks who are, so this is how the drafter explained it to me.
I think perhaps we need to take this offline.
Offline. Yes, ma'am.
Are there any further questions for this panel on this bill? Seeing none, thank you very much for your testimony. And that does conclude the bill hearing on House Bill 1133. We are now going to go to House Bill 1134, which is Delegate Tavares. This is Pharmaceutical Drugs and Devices Gifts to Healthcare Professionals Prohibition. If you want to go ahead and approach the table and bring your panel, and you can begin your testimony when you're ready.
And you should check to see if there is a amended version available.
It was emailed.
Thank you.
At 1:48, so it is in your email, 2:12, so we don't have it in our files, but we do have it in our inboxes.
Okay. So, thank you, Chair Bagnall, and members of this distinguished committee. I come before you again to request your favorable report on HB 1134, which ensures that medical decisions are based on clinical evidence and patient needs rather than the marketing influence of pharmaceutical and medical device manufacturers. This bill prohibits sellers of pharmaceutical drugs and devices from providing gifts to healthcare professionals, including food, travel, and entertainment, that exceed a total combined retail value of $50 per calendar year. The necessity of this legislation is supported by extensive research demonstrating that industry gifts directly influence prescribing behavior, leading to higher healthcare costs and potential public health risks. A study conducted in Washington, D.C. found that healthcare providers who receive gifts from pharmaceutical companies are prescribed 2.3 more claims per patient and medications costing $50 more per claim than those who did not receive gifts. Furthermore, gifts recipients were significantly more likely to prescribe branded drugs rather than more affordable generic alternatives. It is common misconception that small tokens do not impact a medical professional's judgment. A 2016 study of Medicare Part D prescribing patterns found that physicians who received a single industry-sponsored meal costing less than $20 were 2 to 3 times more likely to prescribe and promoted brand drugs compared to physicians who received no meals. Receiving multiple meals further increased prescribing rates. Compared to physicians who received the relationships between the study physicians and the pharmaceutical companies strengthened through multiple meals, making them significantly more likely to prescribe the promoted brand name. Physicians receive gifts totaling less than $500 annually, also prescribed more expensive medications and a higher proportion of branded drugs than non-gift recipients. This influence extends beyond physicians to nurse practitioners and physician's assistants, who now write a significant and growing portion of prescriptions in the U.S. Maryland would not be alone in taking action. Minnesota has long maintained a similar law that makes it unlawful for manufacturers to give gifts to practitioners with an identical annual limit of $50. Other states like Vermont and Massachusetts have also outlawed certain gifts to mitigate conflicts of interest. By passing 1134, we can protect the integrity of the patient-provider relationship and reduce the financial strain on our healthcare system. I urge a favorable report on this bill to ensure that healthcare in our state remains focused on patient welfare rather than corporate marketing. Thank you.
Good afternoon. I'm Adrienne Fu Berman. I'm a physician and researcher at Georgetown. I direct Farmed Out, a rational prescribing project primarily funded by individuals. We do receive some funding from Kaiser Permanente. I've also been a paid expert witness in litigation regarding pharmaceutical marketing practices, primarily on behalf of government. Farmed Out strongly supports HB 1134. Gifts, including meals and including drug samples, trigger gratitude, cement relationships, and affect physicians' choices of medication. My own studies and many other studies have shown that physicians who receive gifts, even one meal, prescribed more expensive drugs and more drugs per patient. Drug samples are a key marketing strategy and are the most important gifts of all. Their purpose is to jumpstart long-term expensive prescriptions. Samples are never for the best drugs. They're used to boost sales of mediocre drugs that have no advantages over less expensive alternatives. Samples increase costs for both patients and payers. Arguments that you will hear against this bill include that the bill will limit education for patients and doctors. However, drug companies provide marketing messages, not objective education. You'll hear that physicians aren't willing to learn without free food, but that's pretty insulting. The physicians and medical students I teach buy their own lunch. You will hear implied threats that regulatory barriers or burdens will cause companies to limit business in Maryland. But what we are asking for is simple, and these threats are idle and time-worn. 7 other states and Washington, D.C. have instituted gift bans. They have not suffered economically for doing so. Bans on gifts improve prescribing. HB 1134 will not only reduce drug costs for Maryland, but will result in better health outcomes for its residents.
Good afternoon. My name is Judy Butler, and I'm a senior research fellow with Farmed Out at Georgetown University, but I'm here as an advisory board member of Physicians for Responsible Opioid Prescribing. I'm a longtime Maryland resident. Gifts influence prescribing practices, and pharma invests in them. In Maryland, pharma spent more than $5 million on food and beverages for prescribers in 2024. Office staff, the ones who control access to the prescribers, get Starbucks and Chinese food too. But that's not tracked. If Maryland is like Nevada, where they do track those payments, that would bring the total to more than $8 million in Maryland. Gifts open the door, and that brings a sales pitch, disguised as education. Doctors don't think they can be manipulated, but they're wrong. Studies show that payments are related to prescribing more targeted drugs, most of the time when there are less expensive, more effective options. Gifts don't just cost Maryland money, they can also cost lives. Maryland is still dealing with an opioid epidemic, and gifts are one of the reasons. Prescribers accepting gifts prescribe not only more opioids, but more expensive opioids. They wrote prescriptions for more days. They had more Medicare patients than doctors not accepting gifts. And every sandwich made a difference. When just one meal was accepted, more opioids were prescribed the next year. Spending, including gifts, was even associated with deaths from overdoses. When researchers asked primary care docs what they heard from opioid sales reps, it was mostly benefits. More than half the interactions mentioned no harms at all. Passing a gift ban would help prevent another drug from having the deadly consequences of opioids. Marylanders deserve that. Thank you.
Thank you for your testimony. I'm going to go ahead and open it up for questions. Are there any questions for this panel from the members? Delegate Kaufman?
Yes. Do you have any idea, and you may have said this, I was just listening, so I might need to write it down. In the state of Maryland or nationally, how much pharmaceutical companies spend on an annual basis with gifts for doctors? On gifts for doctors, rather? And thank you, Madam Chair.
The marketing costs, I believe, are somewhere on the order of 60 billion, but but I'm not sure exactly what part of that is for gifts, especially because samples are not considered gifts in that category, but they should be considered gifts. They are gifts to physicians, which are then re-gifted to patients. But there's a huge amount that's spent on marketing, and the return on investment is about $13 per dollar spent on marketing.
Delegate Hutchinson, followed by Shalega, followed by Hill.
Thank you, Madam Chair. Thank you, Delegate, for bringing the bill to us today. How is this bit different than the Physician Payment Sunshine Act, which I think already covered this or took care of this issue a long time ago?
Can I answer that? The Physician Payment Sunshine Act only requires disclosure of gifts. This would be a ban. Also, the act does not cover samples.
Thank you.
Delegate Shalega.
Thank you. Thanks for bringing this, because I always wondered what the law was about disclosure, and I read that requires disclosure of any amount greater than $13.82, which is an interesting number. Must have had some inflation, something on it, but, and then it looks like you can look at all of that online.
Yes.
So I just, two quick things. One, samples, I respectfully disagree with you, because I've had healthcare providers give me samples to try something before I had to go buy an entire prescription. So I don't think that helped the physician, it really helped me. But more importantly, I did get your amended version of the bill, thank you. Why did you exclude FQHCs?
That was a request, and I think that those are entities that are struggling to receive funds, and so the type of medication that they're receiving are basically generic stock drugs.
There might be others that are serving underserved populations as well, but thank you.
But just a word about the samples.
It's one question, one answer, unless someone else decides that they want to ask a follow-up. Delegate Hill.
Thank you very much, and thank you for the bill. I guess the question is, well, number one, it's one question. Are you able to provide to the committee Maryland-specific information comparing gifts as defined in this bill 2023-24 to 20 years ago? Because I think the things that Delegate Hutchinson and the opposition have mentioned the transparency laws, et cetera, ethic changes within the pharmaceutical industry, et cetera, have impacted for the better, and I'd like to know if you have that data. And Delegate Tavares, are you willing to consider excluding samples from this bill? They're not explicitly stated in there. I know your panel thinks they should be included. Are you willing to consider excluding samples?
Right now, I want to bring it to the subcommittee to have that conversation. I understand that I'm open, but there are people who may not feel so inclined, and we want to be able to have that conversation. That data is a huge database that is available. What I can tell you is that we, as of last year, received $46 million in gifts, the state of Maryland. And you can actually identify and lock it down by state and find out on a per year basis how much we received compared to the overall US trends. And I believe that in the highest amount was in 2020, that we went above and beyond in several degrees compared to the rest of the US.
The question was, can we look back 20 years ago and compare it?
I don't know if that data was available 20 years ago because it started in 2012.
Okay, if we can get that, that would be helpful. 15 years is good.
Delegate Hutchinson.
To the woman at the end, you started talking about the samples, and so I was curious about what you wanted to say, because I see that as, especially in the underserved population, that's a great resource for people to get access to medications that they normally can't afford. So you were going to say more about the samples, and I'd be curious what that was.
Yes, thank you. So it's a common misperception even among physicians that samples go to low-income patients. But in fact, NHANES national data shows us that samples are more likely to go to well-insured patients, middle and upper-class patients. Also, samples are always for chronically used expensive drugs. You never get a sample for something you need for 5 days. Once a patient's on a drug and they're doing all right, the doctor and the patient want to keep them on it, it's an expensive drug. Patients are actually more likely to stay on generic drugs because they can afford them. So it reduces compliance. The samples reduce compliance, and they're always for expensive chronically used drugs, and they increase costs for both payers and patients. And so, yeah, it could save Maryland a lot of money if you were to ban samples. It's the most effective marketing tool that pharmaceutical companies have.
Thank you, Madam Chair.
Thank you. Seeing no further questions, I did want to give you an opportunity to address the opposition because I am equally concerned from what MedChi has said that there is a significant penalty in this and a misdemeanor charge. And I'm wondering what was the decision to make that a significant penalty for the disclosure of, or for the failure to disclose something of $50 with a penalty of $5,000. I don't know if you've had discussions with MedChi on their opposition.
No, not at all, and I'm open to amend.
Okay, thank you. Seeing no further questions, we do have we have a favorable panel and then an unfavorable panel. So if we can bring Allison Taylor.
Thank you, everybody.
Thank you very much. And Gail Groves Scott is in the waiting room, I believe. So Allison Taylor and then Gail Groves Scott, if you want to come to the table, and we will go ahead and you can begin your testimony when you're ready, and we'll bring up our virtual witness.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente. Kaiser Permanente is concerned about the influence of pharmaceutical marketing on prescribing practices, and for a lot of the reasons described by the panelists on the preceding panel. So our organization has substantially restricted those practices within the company. I will note that this is not, there are a number of other industries that have gift restrictions on it, like my own profession in the legal profession. There are restrictions on gifts as well as within the banking sector and other industries. So with that, we urge a favorable report. Thank you.
Thank you for your testimony. Ms. Gail Groves Scott, if you want to go ahead and unmute and begin your testimony.
Hello. I'm Gail Grove Scott. I have a master's in public health and I'm a doctoral candidate in health policy. I'm pleased to be here as I spent my formative years and graduated from college in Maryland, although I'm now up the road in Lancaster, Pennsylvania. I research pharmaceutical marketing, including the role of sales representatives and their public health impact, for which I receive no outside funding. Most relevant for this hearing, I was a pharmaceutical sales rep for 16 years, a drug rep, working for 3 different companies selling a variety of different drugs, including opioids. I used medication samples, free books, snacks, lunches, dinners, office supplies, and other gifts to influence prescribing. They bought me access to an office, access to clinicians. They helped me sometimes just get to the receptionist's desk and catch the eye of clinicians. I hosted lunches, breakfasts, or dinners every single week as a drug rep, especially when I sold opioids, which can't be sampled. Free food was key to our ability to influence prescribing. These tactics worked. I was very successful at my job, earning bonuses every quarter of my 16 years in pharma sales. That experience informed my work now as a scholar studying pharmaceutical policy. I urge you to support HB 1134. The free samples of drugs, antidepressants, birth control pills, antibiotics that I personally provided at some companies were not exclusively used for indigent patients. They were regularly taken for their own use by office staff or healthcare providers as a job perk. We didn't mind. Their chief purpose for us was to, 1, gain access, and 2, keep our product brand name in front of clinicians. Most of the time, I love my job. There isn't anything wrong with the ethical marketing of medications and devices, some of which are innovative and life-saving. But companies should not be allowed to offer services or gifts as inducements. Many medical practices today, including some federally qualified health clinics and clinical ethics codes, do have policies that restrict sales rep access or gift taking, and voluntary industry guidelines were tightened in 2002 and 2009. Did these solve the problem? No, they didn't. My research and my personal experience as a sales person years after those guidelines were tightened shows that they do not. Voluntary policies are insufficient. Gifts to healthcare professionals come as a cost to our health system and taxpayers. There are other ways marketers can help patients and promote their products without buying their way into meetings or influencing prescribers that taxpayers pay for. Thank you.
Thank you for your testimony. I'm going to open it up to the members. Are there questions for this panel? Seeing none, thank you very much for your testimony. We do have one unfavorable panel. So if I can bring Kristen Pard, Josh White, and Steve Wise to the table, and you can begin your testimony when you're ready.
Good afternoon, Chair Bagnall, members of the committee. I'm Steve Wise here today on behalf of MedChi. I did want to thank Delegate Tavares for giving me a few minutes last week to discuss the bill. I have not seen the amended version that's in front of you, so I'm speaking to the bill as introduced. I think it was covered in the proponents panel, but it bears reiterating that we think that this is a subject matter that calls for transparency, and that transparency exists now with the open payments database that Delegate Hutchinson alluded to, where you could plug in the name of any provider and find out who they have accepted gifts from, and the threshold, as was mentioned, is currently $13 and change, and it escalates each year. What you may be concerned about for your constituents is, well, what happens if that database is showing that a physician or other healthcare provider, others are covered by the bill, is accepting a substantial amount of money from a manufacturer? There are specific disciplinary grounds in the existing law under the Board of Physicians for exactly that. And one of the grounds is promoting the sale of drugs, devices, appliances, or goods to a patient so as to exploit them for financial gain. So if a patient saw a significant contribution gift to a physician and felt on top of that that they were being pushed upon with a particular drug or device, they have a remedy, and that is filing a complaint, which can be anonymous with the Board of Physicians. The final thing I'll mention is, in a time when the research funding is maybe, I would say, iffy at the federal level through NIH, we worry a little bit about the stifling of innovation, because NIH typically funds sort of foundational research, and the clinical trials are typically funded more by the private sector. So it takes both, and this would certainly have a chilling effect on that. Thank you, Madam Chair.
Madam Chair and members of the committee, my name is Josh White, again on behalf of the Pharmaceutical Research and Manufacturers of America, or PhRMA. I think everybody is aware that it's very important. Part of the work that PhRMA and the member companies do is ensuring that clinicians understand how new therapies work, which patients may benefit, and how treatments can be used safely and effectively. And because medicine is constantly changing, there are new therapies, updated clinical data, improved treatment emerges every year. The communication between the clinicians and the researchers are very, very important. And we want to ensure that providers stay informed about the new scientific discoveries and treatment advances and options. The bill would impose a strict and somewhat arbitrary cap that, while well-intentioned, could limit routine professional education and in exchange of scientific information that helps clinicians stay current with rapidly evolving medical knowledge. In addition, much of the information, as you have heard, is already publicly available through nationwide federal reporting requirements, and they do so without restricting the exchange of medical information and the benefits to the patients. And for those reasons, we ask for an unfavorable report. Thank you.
Madam Chair, members of the committee, good afternoon again. I'm Kristen Party with PhRMA. Thank you for this opportunity. We respectfully oppose HB 1134, which bans the gifts over $50 from manufacturers to healthcare providers. The biopharmaceutical industry is already one of the most highly regulated in the country, and one of the only industry that voluntarily imposes additional marketing standards through the Pharma Code. Manufacturers are also subject to federal anti-kickback statutes, strict DOJ enforcement, and detailed OIG compliance, governing all interactions with healthcare professionals. These frameworks ensure that patient care, not marketing, drives medical decision-making. This bill is extremely broad and risks undermining legitimate essential interactions that support research, medical education, and innovation. This bill could restrict grants that enable clinical trials, and investigator-initiated research, and scientific collaboration. Maryland currently has almost 3,000 ongoing clinical trials supporting nearly 1.7 million patients and strengthening local research institutions and the state's economy. Barriers to collaboration could slow discovery and reduce Maryland's patient access to cutting-edge treatments. It may also prevent manufacturers from supporting charitable activities simply because a healthcare provider participates. And because samples are not excluded, This bill could limit access to starter doses that get patients on a medication really quickly and also let them try it and fail so that they don't spend money on the actual bill, nor do insurance companies. It's also of note that samples do not have a fair market value because under the IRS, they have no value to report. You cannot sell them. Finally, as has been mentioned, the OPA payments database provides a wealth of information with transparency being the goal, and it's searchable by state, by provider, and by manufacturer. For these reasons, we respectfully urge an unfavorable report on HB 1134. Thank you.
Thank you for your testimony. Are there any questions from the members for this panel? Delegate Hutchinson.
Thank you, Madam Chair. So, Mr. Wise, my oldest brother was in pharmaceutical sales for years, and I remember the days of him talking about the wild golf tournaments and golf trips and elaborate dinners, and then the Sunshine Act came along. So I think the bill is really taken care of by the Sunshine Act, but samples has really caught my attention. And so what's MedChi's position? I never would think of a sample as being a gift to the physician. That's a gift to the patient. And so I'm curious about MedChi's position on that.
Well, I would be giving you that position sort of flying by the seat of my pants because I didn't really hear that discussion until the hearing today. So it's something we would need to think about, but I agree that I've never thought of samples as like an inducement, right, to a physician. I guess I can see where it would be portrayed that way, but I think it's a greater benefit to the patient than it is to the physician or the physician assistant or nurse practitioner that's giving it to them.
Thank you very much.
Delegate Hill.
Thank you. And I guess this is either for Ms. Part or Mr. White. Can you help us to understand what has changed with the transparency and with the ethics rules that are now in place internally, and why a practitioner, a physician, might, after having an educational event, change their prescribing habit other than because they've been brainwashed or bribed by the meal? What reasons might they be that they're changing their behavior?
To clarify, are you saying changing their behavior?
The concern seems to be that gifts are changing behavior without clinical judgment being exercised.
Yeah,
So if we're seeing that after a meal, and companies wouldn't be doing it if it didn't improve their sales, right? So how can it improve sales without being a brainwashing, bribery, marketing, you've been influenced, and therefore you're not making a good clinical decision now?
So I would argue that it doesn't change. Physicians, the ultimate gatekeepers, and they determine what a patient should receive based on a number of things, which are clinical guidelines, the knowledge of the patient's medical history, any comorbidities they have, as well as other drugs that they may be on, which could have interactions with the variety of drugs that exist in a therapeutic class. And one of the biggest things is what, is available through a patient's insurer, or the PBMs, which, as we know, exclude about 1,500 drugs from formularies. On top of that, patients deal with extreme cost sharing, up to 40% for medicines. They have to go through step therapy, prior authorization. And so physicians are dealing with all of this. And I find it hard to believe that a lunch would take precedent over those really significant barriers they have to getting patients the medicine that's best for them.
Okay. And Mr. White, can you address the question I'd asked earlier on the previous panel? Do you know if there are more restrictions of what they look like in terms of what are the limitations that pharmaceutical and manufacturing reps can offer in 2026 as compared to before the Transparency Act and before the ACA and other restrictions went into place?
Okay.
Josh.
Okay, I'm sorry. If you don't mind, I'm going to have Kristen answer that question.
So if we're looking at the Physician Sunshine Act, which has the federal database, that just requires reporting of a number of things and as was mentioned, above a very random amount of like $13 and change. So I think that just brought a lot of transparency. I think over the course of time, you've seen a significant difference, a lot because of the code I mentioned from pharma as well, where there's been a movement away from, you don't see like, a lot of stuff with names on the bags and pens and like all those sort of little, I don't even what you call them. Yes, that's right, exactly. That were probably really prevalent, especially when we talk about the days of, the 90s and things like that have been referenced here today. And so over the course of time, there's just been a significant movement away from sort of what people looked at as terribly concerning, and perhaps they were. And there's just not that standard any longer. It's very, very transparent, and it's very much based on education and making sure that the physicians are aware of the newest drugs, the most innovative drugs, the best drugs that are available at that time.
Okay, thank you, Madam Chair.
Delegate Riley.
Thank you, Madam Chair. So we found out that this bill includes samples, okay? Does it also, whomever can best answer, so does this bill also include non-opioid medications like anti-inflammatory for chronic pain or nerve pain, tooth pain? I see Dan sitting over there. So does it include that as well?
The definition of drug that I'm looking at on page 2 is very broad. Any substance or component of a substance intended for use in the diagnosis, cure, mitigation, treatment, or prevention of disease in human beings is only one part of the definition, but that's the broadest part of it.
Okay, so it seems like it's every medication. Okay.
Seems that way.
All right, thanks. And then just a real quick one. So samples, back to the samples. When I've received samples, it's not even a week's. It's just kind of samples, kind of like a trial period to see if that medication is going to work for your particular situation. And then you have to come back or make a phone call or telehealth and say, this isn't working.
Right.
Let's prescribe me something else. And then it's usually a prescription, at least in my
Right, and
experience.
sometimes you want to get the patient started on it right away, and maybe they can, they can dispense that sample, knowing that person maybe is going to be a little while before they can get to the pharmacy to get the full prescription.
Correct. Okay. Thank you very much for that follow-up. Appreciate it. Thank you, Madam Chair.
Thank you very much for your testimony. I see no further questions, so this does conclude this hearing on House Bill 1134, and we're now going to move to House Bill 1316. This is Public Health Universal Health Care Program Study and Commission. Welcome back, Delegate Ruth, and if you want to bring your panel, and you can begin your testimony when you're ready.
Thank you. Sorry. Thank you, Madam Chair, members of the committee. I do also have some panelists on Zoom as well. Thank you. So for the record, I'm Delegate Sheila Ruth, and I'm here presenting House Bill 1316. I think this committee knows that single-payer universal health care is something I've worked on for a long time, even long before I came here as a delegate. And since I have been here, the last few years, I have sponsored a bill which would have been a commission to study universal health care. This bill is a little different, and I'll explain how it's different in a minute, but the goals are the same. The goals are to find out, can single-payer universal health care be effective, and can it be effective in an economical way? And what types of barriers might we encounter, and how we might deal with that? I think there have been studies done in other states. I know there have been studies done in other states. Also, Maryland did a study 26 years ago. There was a study done by the Lewin Group, which found that single-payer universal health care would ensure everyone had coverage in Maryland for less cost than the current system. But that was 26 years ago. A lot has changed since then, including I believe that was before the Affordable Care Act, and including the way we deliver health care in Maryland, all the work that this committee has done on broadening health care to as many people as possible. So we really, really need to take another look, and that's the goal of this bill, is to take another look. I think there's plenty of evidence that single-payer health care will actually save money and provide more coverage and more benefits, but we need data. We can't just say that we think that. We need data, and we need data that's specific to Maryland, to our population, to the way we deliver health care and all of that. So in the past, as I said, the past few years, my bill has had a commission which was tasked with studying single-payer universal health care. Now, a commission probably is not the most effective way to study something this complex. And so I actually looked at a bill that was passed in Colorado last year, which charges the Colorado School of Public Health to do a study on, and an analysis, basically of universal health care. In addition, last session, when I presented my commission bill in the old Health and Government Operations Committee, the former chair, who of course is now our speaker, charged me with trying to find a university to host what was then a commission, which is now a study. So after conversations during the interim, I have done that. The Hilltop University at UMBC has agreed to host this analysis, this study, as long as we have the funds for it. And I'm going to get to that in a minute. So I'm really grateful for the Hilltop Institute, for the conversations that we've had with them. I think there's some excitement there about doing it. And so that's step one. Step two is the cost. What the Colorado bill did was something that is, I think, unique in that to save the state money, it said that the effort, the analysis would be funded exclusively from private grants and donations, and it would only move forward if there were sufficient private grants and donations to fund it. And so that is the approach that I have taken in this bill as well, because obviously any kind of fiscal note in this climate is difficult. So while there is a fiscal note, it's no cost to the state. It would be private grants and donations coming in and then going to fund this effort. Now, the Hilltop Institute, I spoke to somebody at the the Colorado School of Public Health. I spoke to somebody there just a few days ago. They have now fully funded their study with private grants and donations. They raised $750,000 exclusively from private grants and donations. One interesting thing is that they did not go to any traditional grant-making organizations. That's exclusively grassroots groups and individual donations. They raised $750,000. There are, in my written testimony, some suggestions of traditional foundations or grant-making institutes that might also be ones we can approach to fund this study. But I think the Colorado has shown that it can be done, and they have started the work on analyzing it for Colorado, analyzing the system. Now, the fiscal note, the Hilltop Institute estimates $955,000 to fund the analysis here. That's more than $750,000, not hugely more. It's sort of in the ballpark, but it's definitely more. Obviously $200,000 more. I'm certainly open to working with the Hilltop Institute to see if we can narrow the scope of this down to limit the amount of funds that we would have to raise for this. And then the other thing is, I noticed in reading the fiscal note that we really kind of set the date a little early. We said December, the money would have to be raised by December 2026, which is not a lot of time to raise that amount of money. So I am putting in an amendment to add an additional year for raising the funds on that for the consideration of the committee. I do also have a couple of minor amendments adding people to the commission. This bill does also have a commission, but the commission is not doing the work, unlike in my previous bills. It's just an advisory commission of stakeholders. So the Hilltop Institute would do the analysis, they would do some preliminary work, then they would come to the commission for the feedback. There would be an interim report, and then the Hilltop Institute would do the rest of the work, and the commission would be there to advise for the final report as well, so that they can get feedback from stakeholders, but that you don't have a whole commission trying to debate every little point and every little concern. And so with that, I'm going to turn it over to my panelists and happy to answer any questions.
Chair Bagnall and other members of the House Health Committee, my name is Yvette Delph, and I am a retired physician and health researcher living in Silver Spring, District 19. I respectfully request your support of HB 1316. I worked for 15 years as a physician in Barbados under a single-payer universal healthcare system. There, I never had to ask a patient about their health insurance before caring for them or deciding what treatment or medications I should prescribe. I was free to focus on providing my patients with the care they needed, and I did not have to fight with insurance companies over my patients' need for that care. Patients never received an invoice for their government-provided health care. In 2020, researchers, including from the UMD School of Medicine, published in The Lancet their calculations of the likely impact of Medicare for All, a universal single-payer system. They calculated that Medicare for All would have reduced U.S. healthcare expenditure in 2017 by 13.1%, or more than $458 billion, and that it would save nearly 70,000 lives every year. Medicare demonstrates the feasibility of such a system as it cost-effectively improves the health of our oldest and most expensive age group. Also providing health care for all younger Marylanders would be more feasible and less costly per capita. Maryland legislators have a duty to urgently find a viable state-level alternative to our failing healthcare system. This proposed Hilltop Institute study and report would provide an opportunity to begin this. Please report favorably on HB 1316. Thank you for your attention.
Good afternoon, Madam Chair and members of the committee. My name is Sireen Awadallah, and I live in PG County. My husband and I both work in Maryland. My mother lives here with us, and my children all go to school here as well. We love living in Maryland, and I'm speaking to you today as someone who is deeply invested in the community. And I'm here today to urge you to vote yes on HB 1316. Because for me and my family, just like so many Marylanders, healthcare costs have become a huge financial difficulty. We have healthcare through my husband's work, thank God for that, but we are barely holding on. Every month, we review our bills, we look at how much money we spend on healthcare and how much we have left for everything else, and it doesn't make any sense. My husband and I work hard, we have advanced degrees, and we're doing everything we ever knew to do. But every month, the cost of healthcare is a big cloud hanging over our heads. We're literally choosing which bills to pay just to make it till next month. I've had to use my mother's car since last summer because my car broke down, and I haven't been able to put together the money I need to fix it. I'm sure you know that our story is not unique. Talk to almost any person walking on the street and ask about the cost of their health care, and they'll tell you something similar. Whether it's their monthly bill or that sudden massive amount when you have an emergency, and they'll tell you the same thing. A sudden medical bill can hit you like a heart attack. That bill can give you a shock that's worse than the original medical condition that you have. You all know it's true. We can see how ridiculous it is that this healthcare system benefits private industry executives and their stockholders at the expense of the rest of us. This healthcare system is not made for doctors, it's not made for patients, and it's definitely not made for regular working people like myself. This current healthcare system needs to change. Not any more Band-Aids. We need bold and transformative action. And since we haven't overhauled the healthcare system at the federal level, why not do it right here in Maryland? Maryland can create a single-payer healthcare system that's publicly funded and privately delivered. Maryland can take care of its residents and pave the way for other states to do the same. So please vote yes on HB 1316. Thank you.
Thank you for your testimony. We're going to turn to your virtual witnesses, so if we can start with Michael Santome.
Hi, can you hear me?
Yes.
Okay,
Go ahead and give us your testimony.
Thank you so much. Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Mike Santome. I'm a resident of Harford County, living and working in Bel Air. I'm a husband and a father, and I'm also a nurse manager helping manage a care transformation organization in Harford County for a large medical system. I fell in love with nursing because being able to make a meaningful difference in the lives of others is a profound honor. So thank you for the opportunity to testify today in strong support of HB 1316. Every day, my clinical teams and I are forced to navigate a complicated, multi-payer, profit-driven healthcare system that places a constant stream of administrative hurdles between our patients and the care that they need. In the Medicaid program alone, we're losing up to 13 cents on every dollar to the administrative overhead and profit margins of private managed care organizations. That money is then being siphoned directly away from the most vulnerable patients in Maryland. Furthermore, as commercial premiums rise dramatically, carriers erect so many barriers that even patients with proper insurance are functionally unable to access their care. We all know that our system is not working and are in urgent need of a data-driven blueprint for a better system, something that HB 1316 provides exactly for the state of Maryland. If there are concerns about the private funding requirement, look to Colorado, as Delegate Ruth mentioned. Just last month, advocates there successfully secured $750,000 in private philanthropy to fully fund their own single-payer feasibility study. Maryland's networks can absolutely do the same. As lawmakers spend the next few years discussing system-wide improvements, HB 1316 will serve as your essential mathematical engine. It ensures that when you're ready to enact sweeping reforms, you have the rigorous state-specific data needed to make fiscally responsible decisions. I look forward to a system that finally prioritizes patients and providers, directing every healthcare dollar toward the prevention and treatment our community deserves. Given the urgency of the healthcare crisis, we can't let the fear of the unknown prevent us from exploring this option and simply doing the math. I urge a favorable report on HB 1316. Thank you.
Thank you for your testimony. Alankrita Olson, if you can unmute and then begin your testimony.
Thank you. Good afternoon, Madam Chair and members of the Health Committee. My name is Alankrita Olson, and I'm a preventive medicine physician and member of Physicians for a National Health Program. I request your support for HB 1316. Our current healthcare system does not work for the most important people in it, patients and clinicians. This bill is an opportunity to understand how we can improve access to care, improve health outcomes, while decreasing costs for all Marylanders. Health insurance linked to employment means that not only do you lose income, but also coverage when you're out of work, as so many federal workers in Maryland experienced last year. Moreover, insurance does not ensure access to care, with narrow networks and out-of-pocket costs pushing people to delay care to the detriment of their health. Maryland has always been exceptional in tackling healthcare issues and adopting innovative solutions. We established an all-payer system, unlike every other state, and have since developed that model to not only drive down costs, but also improve care delivery and health outcomes. As a result, we are armed with Medicare and Medicaid waivers, which make it easier to implement a single-payer model here than in any other state. It would streamline access to healthcare coverage for patients, billing and payment for healthcare services for providers, and data collection and quality improvement across the state. Under a single-payer system, preventive care is prioritized to lower healthcare spending, unlike our current profit-driven system, which benefits from acute care delivery. Such a model would help our most vulnerable populations, rural residents and people of color. Rural areas have higher rates of unemployment, lower income, and chronic disease, with 45% of heart disease and 57% of respiratory disease in these populations preventable with regular care. Yet these areas have seen the steepest rise in hospital and clinic closures, leaving many with critical shortages for primary and specialty care. People of color account for over half of America's uninsured. They're more likely to deal with medical bills and have overall worse health outcomes, with Black Americans more likely to die from diabetes and heart disease. Yet in the VA system, Black men are less likely to develop heart disease and have lower death rate. With money not wasted on administrative overhead and more able to go to care, guaranteed universal comprehensive coverage for every Marylander with a single-payer model is a step toward improving health equity. Therefore, I urge the Health Committee to issue a favorable report on 1316. Thank you.
Thank you for your testimony. Are there any questions for this panel from the members? Delegate Hill.
Chair, thank you, Delegate Ruth, for this bill. I'm very excited about this bill. I'm looking to see how it works well and complements the Reimagining Healthcare bill. Can you clarify who is responsible for raising the funding? Is it Hilltop? Is it the state? Is it Delegate Ruth?
The bill is actually silent on that, and now that you asked that, we probably need an amendment to clarify that.
Seeing no further questions, thank you very much for your testimony. We do have a favorable panel on this bill. So if I can bring Jackson Corcoran, Ken Phelps Jr., and then virtually Nisha McCoy and Edward Fishman.
Madam Chair, Jackson Corcoran is my staff member.
Oh, all right.
So, well, signing me up.
Thank you very much for that information. So Ken Phelps and then our two virtual witnesses. So Mr. Phelps, if you would like to go ahead and begin your testimony.
Thank you. Thank you, Madam Chair. I am Ken Phelps. I'm with the Episcopal Diocese of Maryland. And I hate people that read testimony, but I want to start with a quote, if I may. Resolved, the 76th Convention of the Episcopal Church urged passage of legislation establishing a single-payer universal health care program which would provide health care coverage for all of the people of the United States. Be it further resolved, the General Convention direct the Office of Government Relations to assess, negotiate, and deliberate the range of proposed health care policy options in the effort to reach the goal of universal health care coverage and to pursue short-term, incremental, innovative, and creative approaches to universal health care until a single-payer universal health care program is established. And be it further resolved, the Episcopal Church will work with other people of goodwill to finally and concretely realize the goal of universal health care coverage. You are people of goodwill. And House Bill 1316 represents, as it says here, one of those incremental, innovative, and creative approaches to get us on the road to universal health care. Our church teaches that health care is a basic human right. And the sin, if I can bring that term into it, of it is that we have made it a commodity, which very few can afford. I worked for a couple years between gigs in the priesthood for a healthcare insurer, which prided itself not on the medical plans it had, not on the coverage it allowed, not on the many options it offered in the market. It prided itself on the fact that 34 cents of every dollar was shareholder investment, was returned as equity to shareholders. We need to do something. We are 34th in the world in healthcare. Our system is ranked 34th. This is possible. This is doable. It is the humane thing to do. The founder of our movement, if you read your Bible, gave this stuff away, gave it away. We urge a favorable report.
Thank you for your testimony. If I can ask Nisha McCoy to go ahead and unmute and begin your testimony.
Thank you, Delegate. Could you hold on a second, please?
Yes, do you need a moment? Would you like us to go to Mr. Fishman and come back to you?
No, I'm ready.
Okay, you can begin your testimony.
I'm ready now. My name is Naisha McCoy, and I am testifying in support of House Bill 1316 because I have witnessed firsthand how our Maryland current insurance landscape prioritizes bureaucracy over the House of Marylanders. I frequently manage health issues that require recurring medication. Most often, I pay between $1 and $3 in copay. But depending on the specific medication, those out-of-pocket costs can reach as much as $10. While these individual fees may seem small, they are cumulative, acting as a recurring financial strain on people with a fixed income. I am also a wheelchair user. My independence depends on having functional equipment. Yet, I often have to battle insurance algorithms that override my doctor's assessments, forcing specialists to drop patient care just to write letters of medical necessity to prove that I need the equipment required for me to move. This systematic failure also impacts the people I care about. A close friend of mine has lived with a seizure disorder since he was 9 months old. It is medically documented that he requires a specific brand name medication to remain seizure-free. When he is forced to take the generic version, his seizures become stronger and more frequent. Yet, the insurance system constantly denies the drug through automated prior authorization protocols. Once, we spent an entire week fighting with the insurance.
Can you please wrap up your testimony?
Yes, ma'am. To authorize the medication his neurologist has confirmed is a clinical necessity. We need the proposed study in HB 1316 to build a healthcare system where no Marylander has to fail first or lose their independence because of a fragmented insurance market that values bureaucracy over human lives. I respectfully ask for a favorable report on HB 1316. Thank you.
Thank you for your testimony, and thank you for sharing your personal experience. Edward Fishman, if you can go ahead and unmute and begin your testimony. Mr. Fishman, you need to unmute, please.
Sorry, gotcha. I thought I was unmuted before, sorry. I'm Edward Fishman. I'm a longtime resident activist in Montgomery County and a leader in Our Revolution, Maryland. I really want to express my gratitude to Delegate Ruth and the co-sponsors for bringing forward this long overdue but very timely legislation. When I worked with Delegate Ruth in launching Our Revolution nearly a decade ago, universal single-payer health coverage was at the top of the agenda. We had great optimism then. There was movement to implement this at the state level and various places, and Senator Paul Pinsky led the effort here in the Maryland legislature. Ben Jealous made the plan a major plank in his campaign for governor, and he received over 1 million votes, more votes than any non-incumbent had ever gotten. Then the focus turned to facing down an assault on our democracy and debates over huge foreign wars, and we lost the momentum. So in Maryland, we've pared back our ambitions to ask for just for the study in the bill before you now. It's imperative to regain that lost momentum. In 2026, we face different, much more urgent circumstances, with 10,000 Marylanders having lost their jobs at the federal level and affected local businesses as well. The cost of purchasing insurance on the private market has skyrocketed. It should be clear the current status quo is untenable. We see some light at the federal level with much greater support for the national plan. We have co-sponsors Raskin, Mfume, Ivey, Elfreth, Delaney, and Senator Van Hollen. We may even have the entire Maryland federal delegation support next year, but two things that won't change are the filibuster and Republican opposition, so it will fall to states to ensure all residents have health care coverage without being at risk if they lose a job. I could go on about why the public plan would be better, but I don't need to do that. We're here to ask the legislature to commission an independent expert study, nothing more. Let the experts study whether this will work for Maryland. Every year we delay will have real, sometimes tragic consequences in the lives of Marylanders. Passage in the House this year will signal the other body that this is serious legislation. Let's get the ball rolling. I urge the committee to issue a favorable report on HB 1316. Thank you.
Thank you very much for your testimony. Are there any questions for this panel from the members? Seeing none, thank you very much for your testimony today. This concludes the bill hearing on House Bill 1316, and this actually concludes our bill hearings for today. So thank you very much.